Okay, I hope everyone can hear me. I'm following PPE on pulp nonfiction today. I have with me, sorry, it probably sounds way better that way, Kris Klimek, a classmate of mine from dental school back in the previous century. He's now on the North Shore. We were in dental school together, had a great time. Thank God they didn't have social media back then, the shenanigans we got up to, but there you go. And from dental school, your wife was in medicine and had different residencies, so you popped her, or was it just Alberta? You just went to Edmonton?
Yeah, went to Edmonton, survived the cold, came straight back.
Yeah, saw some good hockey, and came back to see the Canucks in Vancouver. Anyway, let me take off my headgear here. Yeah, and then you've been working on the North Shore.
Yeah, been there
Mountain
20
View.
years or so. A little mountain biking, a little skiing, a lot of working.
Yeah,
but,
yeah. And you did some downhilling this year. Yeah.
With Joel, I have to say, he was
Franz Klimek.
fastest. But we did a little downhill race that raised a bunch of money for Cancer Ride. I'm looking forward to that, hopefully in the summer. So
yeah,
we'll see. We'll wait and see.
Irony of ironies, because we're dentists and we're skiing downhill, I was like, oh, I forgot to bring up masks. I was going to ski with a mask. Absolutely. Imagine how like that would have looked now, right? Because everyone just, what the hell are you skiing with a mask for? But anyway, blah, blah, blah. I digress. Kris, it's wonderful to have you on Pulp Nonfiction. We got a little bit of background on you, which is fantastic. And you're going to start off our interview talking about the moolah, money.
Well, yeah, I mean, as a general dentist, we have our hands into a lot of different areas of dentistry, and each brings its own little problems. The biggest problem we all face right now, I think, is lack of money, lack of work. So a couple brief words about economics. First, EI. We're not usually eligible for EI. There are lots of exceptions, exemptions, rule changes. So I would try to register for EI if you're paying yourself and you're paying various deductions as I do. We may be eligible. You know, I wouldn't hold out too much hope, but it's possible. You can register via the Canadian Revenue Agency website, CRA. There is a My Business section. You can register yourself, your business, and Joel will have a link to that. I think
we'll put that up on the site there. Yeah.
Yeah. I think a lot of things will kind of flow through that. Banks, your local bank will also administer a bunch of loans. I believe BC will have some loans for small businesses up to
and
4,000.
Other provinces are probably doing that as
probably
well.
The same. So talk to your bank manager. In BC, up to 40K, maybe 25% forgiveness. So worth checking out. I think we probably know, most of us, personal taxes are deferred till August 31st. As are corporate installments. Didn't know that yesterday. Today, new news. Corporate installments are going to be deferred till August 31st. I would not call CRA if you've given them post-dated checks. Probably putting a stop payment on those checks is going to be more effective than trying to reach someone at CRA. God knows it'll take less time. So might want to think about that. Employer health tax in BC for all us lucky BC dentists, we get to pay another, about 6K in my case, but that's deferred till September 30th, 2020. ROE, you've probably all done them for your employees. Next, professionally, I think none of us are doing elective care anymore. I hope not. That would be totally silly. We also know that BCDA has been working hard to give us an algorithm to help us determine what is elective care, what isn't. Also, how to screen our patients in terms of what do you need to look for to determine if a patient should be seen in your clinic and what treatment is appropriate. So definitely check out this little algorithm on the BCDA website. I did find it useful. I'm glad it's there. It's been recently, today, I believe, has been supplemented by another similar but slightly more exhaustive flow chart from the BC Association of Oral Maxillofacial Surgeons. I think that one's very good as well. Essentially, they will help you decide who to see and what level of treatment is safe to provide, assuming you have basic PPE, personal protection equipment. To get into anything that creates any kind of aerosol, you need full tested N95s. I'll let Joel maybe talk about that. He's got the mask. He's donned the Darth Vader look there, and I think you need that. Whatever you can get on, get on. If you're creating aerosols, the risk is very, very much higher. First steps, I guess, if you do have an emergency call, I'm thinking always on the phone as much as possible, as much history. If you have a link you can set up to your office so you can look at your chart data, if you can look at your intraoral films, past films over a remote connection, that'll help you out. So you might want to set that up in advance. You get the call, screen them if you can, treat them medically, antibiotics, steroids, whatever, you guys know what to do. But assuming it's something that does need to be seen in office, then you're going to follow a strict protocol on what you're going to do when you get there. I guess first of all, let's, what are we going to see in office? So,
well, hang on.
Yeah, go ahead.
Let me reel you in there a little bit. This BCDA non-elective dental treatment algorithm, the flu-like symptoms, I think it's a good idea for everyone to refamiliarize themselves with what flu-like symptoms are, right? And flu-like symptoms themselves aren't necessarily an indication of flu, but they certainly do give us a red flag as to what to look for. And with your wife being a physician, we have to be cognizant of the fact that a patient might downplay their flu symptoms and upplay their tooth pain to get
treatment. They may tell you,
yes,
not the whole truth.
We have to be on our game, and I think a good screening protocol is receptionist screens them, they get past her, you screen them, preferably calling the patients either the morning of or the day before the appointment, just to double, triple check everything, have a very good idea of what's going on with the patient beforehand. The BCDA can't cover everything, but I'm just perhaps adding to that. The one thing I did find disappointing about their algorithm was travel.
And basically travel outside of Canada.
Well, I travel from the bedroom to the bathroom to the kitchen. Like, that's an undefined word, just travel. Okay.
International travel, I would say for sure.
Yeah, but they didn't even put the word international, like they didn't put anything. So
travel history, maybe that's what they're going for.
Well,
but I would definitely say
let's define our terms. And so they put a term there and it's undefined. So, I think that just leads to confusion. So, what are they talking about? I mean, we all have an idea, and I think we all have a very good idea, but I just think that that's a shortcoming on the form. Yeah. And
I just remember 6. I was talking with someone else and they told me, fever, check the travel history, shortness of breath, myalgia, so body aches. That's one that I didn't see a lot of on the flow chart. So myalgia is a good one to ask for.
Yeah, but check the travel history.
Check it for sure.
Not just for interest sake. Like, what does it mean? Like, okay,
what's the weather like?
How was Tibet? Like, did you enjoy your time in Tibet? Like, what? Like, no. Like, travel. And now where the things are, travel to the U.S., that's a red flag, right?
Washington next door.
Yeah. And you're on the North Shore. Well, travel to an old folks home. Maybe that's the thing. Like, travel, please. I think it's worth defining. And right now they just have the word travel, and like, why would you put that word and have nothing?
Yeah. Well, I'm sure it'll get better over time. So
yes,
obviously if there's a positive travel history in international, you want to be double careful. And then we talked about myalgia, cough, and then a new one actually that came to my attention: loss of sense of smell.
Yes, can you go over those signs for COVID positive? Because I'd like to know those, and I think people listening to this podcast would like me to shut up and for you to say what those symptoms are. Right
like that.
now.
Fever, number one. So get the patient actually to check their temperature. Travel history, 2. Shortness of breath, 3. Myalgia, body aches. If you're aching, good chance you're COVID positive. Maybe something else, but right now that's the one we care about. And then cough. And number 6, loss of sense of smell. So that's a new one, and it's apparently fairly highly correlated with COVID-19. So you want to be extra cautious for their screening, and if they are feverish or have multiple signs in that category, then you may want to refer them for medical treatment of that problem before you see them in office. Diarrhea is a 7th kind of weak sign, not great correlation. But
what's the last one?
Diarrhea.
Yes. I thought that one was missing. Yeah, perfect. Yeah, no, that's great. So we screen them for that, screen them for the fever. For the most part, this form is super fantastic, and I totally agree with you. The oral surgeon one's very nice, a little more details. So they're very complimentary. You know, you read the oral surgery one, lots of details, and then you can go to the BCDA one to have a broad guideline with.
Yeah, and it's great because it's simple. You can look at it if you're on the phone screening. It'll kind of help you through, make sure you don't miss steps. But I would say, yeah, if you do decide that, you know, it's someone that's bleeding, it's someone that's had some injury.
And if you're not from BC, you're not allowed to read the form. Is that not stipulated right? If you're from Alberta, forget it. We don't want your pipelines, and you can't read our forms, right? But no, it's open to everybody.
No.
But it's only in one of the official languages. But there you go. It's I think it's quite helpful, and it's really useful. And the colleges come out with guidelines. And can you speak a little bit towards those, Kris? Because I think you're a little familiar with the college ones.
Well, you know, yeah. So the guidelines, as far as I'm aware, true emergency, you know, facial space swelling, bleeding, those are true emergencies. Unrelenting pain, as Joel says, all it does, that's all you can think about. There's nothing else on your mind. The pain is that bad. So those are true emergencies. If it's not that, you don't really want to, you know, deal with it too much, other than assessing over the phone and trying to treat them medically. So again, emergency infection, cellulitis, trauma, bleeding, and then unrelated pain.
Yeah. Now those are all good. And yesterday, I was drinking the Kool-Aid and I was loving it. I was antibioticing the patients and saying, you know what, don't come in, la da da. And the health minister came out and said, this is probably going to last all summer. You know, we're going to have weirdness all summer. And then we're going to get a second wave. And now I'm thinking, well, hang on a minute. If I have someone and they have swelling and I put them on antibiotics, okay. But I can't see that being a solution for 4 months. And I can put them on a second round. I still think we're going to be a little ways away from 4 months. Maybe we can make it to 4 months, but there's a little bit more variable there. A few days ago, because this situation is so dynamic, I was saying, okay, I'll put them on antibiotics, and you know what, come back another day because, you know, the world's going to get a little bit cleaner and normalcy is going to be somewhat approached, and we can do the root canal later date. Now I'm thinking, well, hang on a minute. We know where you're going. You've got an abscess tooth, and it's problematic. Yeah, we can put you on antibiotics and not do it. It's not a true dental emergency, but do we need to wait now? Like, how close to the cliff edge do they have to get before they treat? Because I'm not super busy. You're not super busy. It's almost like the hospital emergency rooms before it floods. Maybe we nip them in the bud now, knowing that it's an abscess tooth and it needs treatment. I'm just throwing that out there because I'm a bit concerned. We're kind of icing the puck. Like, everyone's around the goal and it's chaos, and you just shoot the puck to the other end because you know it's quiet down there, right? And it's like, I can't deal with this. You know, my defensemen are crap, and you just ice the puck. You send it down there because it's quiet down there in the future, and you're like, well, maybe it won't be.
And I think that's where these guidelines have come out now. Everyone's had a little, couple days to think about it. And that's why we're seeing some of the guidelines, even from oral maxillofacial, they're saying in properly equipped facilities with extensive PPE. I did notice there's root canal therapy as part of emergency treatment on there.
Yeah.
Under certain cases, again, with full protective gear, fitted masks, etc.
No. I get all that. That's not changed, right?
Yeah.
So we got all that gear, and we got all that, and we're sitting at the start line, and we're in idle, right? And we're like, no, I'm not going to go yet. No, I'm not going to go yet. No, I'm not going to go yet. I'm waiting until it's a dental emergency. Wait until it's dental emergency, and I get that. But 4 weeks from now, it might be clogged, and you're like, okay, I'm ready to go, and it's like, what? Like, then we got patients coming out of left, right, and center because all these dental clinics are closed. So the patients, in some regards, are coasting on fumes without dental care from general dental offices, and they can do that, but not forever.
You're afraid of the tsunami.
Yeah. But there you go.
Yeah.
I was searching.
I read some of the other documents they put out, and they did say, we're not going to step on your clinical judgment. We can put out recommendations, and that's why they didn't absolutely close everybody, because they know that people need emergency care. Mm-hmm. And I think they are leaving practitioners some leeway to use that judgment and judge where we are, because the situation is going to evolve over the days, weeks, maybe months. And we're going to have to use that professional judgment and weigh the risks of treating versus non-treating. And like you say, if you have everything, it's month 3 and 4, round 2 of antibiotics is just getting worse and worse. Well, which course is best? So,
and how long is it good to be on ibuprofen?
Well, not at all. Apparently, ibuprofen is one of the things you don't want people on with COVID.
Yeah, but with irreversible pyitis, you're trying to reduce the inflammation. So
yeah, not many great choices. So I think
just exercise your clinical judgment. It's like, I don't know. I almost feel like they're saying, "Do you feel lucky, punk?" Like, what? Like, help me here, please. Yeah. So, I guess if it's severe enough, fine, you treat them. But I'm a bit worried about those cases where we're icing the puck, we're sending the problem down to the other end of the rink, and we'll deal with it another day. And you're thinking it could be crowded 4 months from now.
It could be a lot worse. It could be a lot harder to treat. We take more visits. So judgment, but I do think the key message is, if you're going to do anything that's possibly going to require an aerosol, think about it before you start. And if there's a chance, refer it to a clinic that is properly equipped if you're not. Because the risk level goes up exponentially as you generate that aerosol. And basically, I think we know even suction generates. That surprised me a little bit. Even suctions generate aerosols. So
yes.
During on your high volume, you think, oh, it's just sucking air in. Well, no, it's creating eddies and it's creating aerosols too. So,
but it's a necessary evil, because when they say when you are cutting in the procedure, you need the high volume nearby. But right. Don't go nuts with your high volume unless you got a handpiece on and you have that high volume near it. Is that right?
Exactly. That's assuming you're already gowned up and you got enhanced PPE and all the rest. Then it makes sense, I guess. But don't use your suction if you're doing just an exam. The suction, you don't have your full bunny suit on. The suction's not your friend. So that was something I learned in the last few days. Was an immediately obvious thing with air water syringe. Well, we kind of assumed that, but I think the suction was a little bit new for me. So what do we treat? Well, bleeding, there's a little algorithm for bleeding. If you got someone that's, for whatever reason, had knocked a tooth out, they're bleeding, pressure. I think we know some of these steps. But I learned 1 or 2 from an oral surgeon I spoke with. Pressure in a tea bag, we know that one. Mm-hmm. New one for me was gauze soaked with 50-50 water and hydrogen peroxide, just standard issue from the drugstore, 3% hydrogen peroxide. That will also help staunch bleeding. And if you've really got someone that is really having a serious bleeding problem that those previous steps haven't worked on, You can have something compounded called tranexamic acid mouth rinse. You have to have a compounding pharmacy, Northmount compounding pharmacy on the North Shore, standard dilution, and you moisten the gauze and have them bite on that. So that should take care of bleeding issues. Avulsions, well, again, is a true medical emergency. Would you reimplant that tooth? I probably wouldn't today, because we can replace the tooth in the future with an implant. So would you risk future infection, all the problems that Dr. Fransen can tell you about with avulsed teeth? I would probably put it off at the moment. Repositioning, maybe have the patient reposition the tooth if it's possible. Okay, put them on antibiotics, maybe consider that. Intrusions, again, same thing, let it self-erupt. Other than that, you've got the flow chart for kind of all the other things. Beyond this, I guess we should maybe say a few words. If you are going to have someone in the office, you're going to see them. A couple of things that I hadn't really thought about that I've learned over the last few days, but you might want to prep your office before the patient came in. Joel had a great instruction list for the patient, what to do before your visit and after, so refer to that. But within your office, you should get in there first and strip the operatory bare, like as bare as you possibly can, because we're assuming that all patients, even if they're asymptomatic, are going to be COVID positive. So you have to assume that you're going to be doing an incredibly thorough wipe down of everything. The less stuff you have in there, the better. So get rid of anything that can be moved out of that room that you're going to treat them in. When they arrive, have them wait in the car, get yourself ready. Standard mask, standard gloves, have them come in, throw a mask on them, and then take a temperature. That's your first step. If the temperature's high, again, refer them for medical treatment. I think Dr. Fransen there made an excellent point. If they pass test number 1, an extra oral x-ray. You don't want them coughing on you. You don't want them vomiting with intraoral. I think that's, good advice, extra oral, if you can limit it to that. At that point, hopefully you have enough information to decide if you need to see them or not, whether you can manage them medically. If you do need to see them for clinical exam, get gowned up. Mask, I would, if you have access to an N95, even if it's not fitted, I'd throw it on. You're not going to be creating aerosols unless you've had fit tested. But I would get as much protective gear on as you've got and have them rinse. So step number 3 is, before you actually get in there, have them rinse with hydrogen peroxide diluted 50-50 with water. It's very good at killing viruses that may be in their oropharynx. Commercially available, it's known as Bitrex, 1.5% hydrogen peroxide. So either buy that or mix it up yourself, 50-50 with water. And
you can't get hydrogen peroxide in pharmacies very easily. I've been around, so I'm gonna try having a look at Bitrex. I also got a compounding pharmacy to make up the 0.2% povidone iodine mouth rinse, and I also got some Listerine, but I didn't have the hydrogen peroxide in it. But yeah, you want to have them clean their mouth as much as possible, and then of course you got to use a rubber dam. And then when the teeth are underneath the rubber dam, you want to rinse them with bleach and alcohol. I mean, just napalm the teeth a little bit. I mean, it also, you don't want them swallowing it, but there's also a test for your rubber dam. But wipe the area down so it's as clean as possible.
Yeah. And if I'm thinking, what am I likely to be doing if I'm seeing someone in an office and it can't be managed medically, it's probably extraction.
Yeah.
Then, if you're doing extraction, make sure before you start, make sure it's well within your comfort zone, because you don't want to get into a position where suddenly it doesn't go your way, and then you take your handpiece out and do what you do with your handpiece, but now you can't do it. So what do you do next? So just keep that in mind as far as case selection. I know I'm going to be a little bit more cautious in that respect. because there are going to be clinics already. Oral maxillofacial surgeons are setting up clinics. They're very close to opening. They have a website. We're going to give a link to that where you can refer those more difficult cases. But do keep in mind, do what you can. They are going to be very limited in how many cases they can treat. They tell me maybe 3 or 4 a day because of how extensive the cleanup is involved after treating a case like that. So, do what you can safely, as long as you feel like you've got the proper equipment.
So, Kris, you have a gnarly 7 that is infected, causing the person insane pain. Antibiotics aren't touching it all, and they're not sure they're going to make it through the day. I'm busy. Oral surgeons are busy. It's down to Kris. Down to you, man. You're between the person and a bridge. You're right. And so
size and drain if they're that bad, they probably have some infection. Yeah. Again, if they're just pain, if it's an irreversible pulpitis, great suggestion from our endodontic friend, Dr. Fransen. Maybe some steroids. So what were you saying? The 4 milligrams of dexamethasone?
Q6H. Yeah. So 6 tablets. But the person can be pregnant. They can't have diabetes. They have to be healthy and no other infections, right? And no COVID warning signs at all, because their immune system is down a little bit. It's only for 24 hours, so it's going to have a big impact on that tooth with irreversible pulpitis, but a small impact on them medically because it's for a short stint. You can give them long-acting infiltration bupivacaine, and yes, if you could take the tooth out of the occlusion, but you're creating aerosols, so we don't touch up with a barge pole.
Yeah. So if it's gnarly, if I don't think I can take it out, if I think the roots are so bad that there's no way it's going to come out, that doesn't make sense. I would work really hard to get them into one of multiple clinics. There are going to be multiple oral surgeons, and I think that's what they're counting.
Okay, but that steroid thing can buy a week or two.
There you go. So
in theory, it's not proven. There's no research behind it. So please don't take this as gospel, but it has been used by other people and it does appear to be useful. But this is us shooting from the hip, trying something that normally we wouldn't bother doing because we'd have more flexibility in treating patients. So it's our best efforts in this trying time.
Yeah. And I would say, luckily there's multiple clinics coming online that can treat these more difficult cases, more challenging.
Yeah, but some people are in rural areas, some people are far from it.
Right.
You're talking very specific North Van, but
across Vancouver. But if
okay, fine, North Van, Vancouver, but like go nowhere, Saskatchewan, go somewhere else, Newfoundland. You're quite a drive away from everywhere. I mean, some people are, So if you're stuck, you're stuck.
Yeah.
The other thing, so let's say, Kris, you said, okay, no, forget it. This tooth is coming out, right? And you're going to pull that 7. That's a second molar for our American friends. And the crown breaks off, and you're looking at some nice root tips there.
I'm less worried about it because I've got access. I can still work on those root tips, use whatever hand instruments you
elevate them out
normally, try to get it out. If you can't, at least possibly you've created some drainage. There's not a crown in the way that the pus may drain.
Let's say it was irreversible pulpitis, so no pus.
Okay, well,
crown comes off. A little nerve there.
Well, you could try a hand file. You could put a little bit of
speaking to me, you're speaking to me, man. I was pushing for the hand file.
Like
I'm the endodontist, man. Never mind all that other garbage. Bring out the endo stuff. All that other stuff is boring. Yeah. Okay. Now you made me happy. Now you can talk about whatever the heck you want to. I had to bring endo in again.
Yeah.
I was getting a bit bored there. You lost me with all this other stuff.
I know you don't have many tools in your office.
No, and
no hammers, no chisels.
Yeah. That's perhaps for the best. It's a big issue about a little tissue. That's right. So sorry.
Those are all things that we're going to deal with as we come across them. I think those are all good points that some of my colleagues have enlightened me. I think we're still learning in, how to deal with these emergencies under our current circumstances.
Mm-hmm.
And, I think we're in it together. Do your best. And I guess there's people you can call, even if it means putting it off till next day. Well, there's a list of links that, if you don't know what to do with it, you come across something we haven't covered, well, maybe next day antibiotics work a little better. Maybe you get a little bit better anesthesia. Maybe that route comes out. Maybe it just can stay in there for the next number of months. Many times, once you create some drainage, situation improves. So I think in those cases.
Now, some practicalities.
Mm-hmm.
I've seen some posts on social media of front staff in disposable gowns and N95 masks. This is the meters and greeters and money takers.
In my office, personally, I'm not going to have any front staff. I'm going to take the call.
Okay. Wait. How about that? How about that? I mean, just how about the gown stuff? That's what my question was. They're there. If someone
did have such staff.
Yes, thank you.
Then I would not feel it necessary for them to use that.
Bing. Yeah, that's what I was going for.
Use that personal protective equipment.
Yeah.
Because it's very limited. And no one in the front is going to be exposed to aerosols that we have to be protected against, even in hospitals where they expect a lot more sick people who are possibly COVID positive. Their frontline staff are wearing regular surgical masks. And I think social distance at the front desk, if you are having a staff member there, maybe having a little plastic shield, or at least keeping the patient back 2 meters. You might have the line in the carpet and say, don't cross, don't get too close to the staff.
Yeah,
so
we bought the shield for our office too. And in some regards, a line does need to be drawn. The workers in the back are in the trenches, and the person at the front, it's a different field. Yes, we're having universal precautions, but that does not mean everybody is exposed to the same contaminants and to the same level. And the only reason I'm mentioning it is not because I want front end staff to get sick and die and go away, but we need to be concerned about preserving our stuff, because I can't get a disposable gowns to save my life. And the N95 masks are like few and far between. And then I see these people posting it at the front staff, and they got better stuff than I do. And like, so maybe in some regards, it's great, but some people are overcorrecting, and it could be for the worse of everybody, because it's not necessary, and
you don't know how long this is going to go on. So
yeah.
Your supply, you think you're well supplied right now. Well, maybe or maybe not. Depends how long this goes on. So I would conserve your most precious supplies, like those gowns.
And it's potential that your staff could even be.
There's many people who don't, like, the people who are running these clinics, like Dr. Fransen and maxillofacial surgeons, who are, under high risk.
But like, for instance, you could look at it a different way with your staff. Your front end person is like, okay, they come in, the patient puts on a mask, and then when the patient comes out, like, it's just a payment thing, right? Give us your credit card. I'll talk to you about your credit card when you're in the car, right? Like I've got your numbers, I've got your everything.
Everybody else
just do it over the phone.
Yeah.
I don't need to take your credit card when you're a bloody mess.
No.
Take this. No thanks. Well, Xerox. I'm sure half the people don't know what the hell that word is, but I just said. But for those,
you just dated yourself.
Yeah. Photocopy or scan the credit card. The receptionist, when they come in, right, and then when they go, it's like, okay, well, this is what we're gonna do. We're gonna talk over the phone, right, and get the payment that way. That way, the receptionist can feel a little bit more protected that they're not taking the card.
You don't need to handle things that the patients touch. Not at all. I agree.
The great unwashed. Out you go. We're done with you.
Yeah.
But it's really important
to
the
think
patients
about those issues, because why spread the possibility of infection? you can do that over the phone. We don't need a physical piece of plastic. That's easily handled. So yeah, I think those are all good points. I am happy to see that we have more guidelines to use. I would definitely refer you guys to the BCDA site. I think that's been helpful for me. The one other thing that I haven't talked about is for people doing ortho, have a quick look at dental monitoring. Look them up on the internet. It's a little system that provides a cheek retractor. The patient snaps the camera into it, kind of a good view of their teeth. You might be able to help with an emergency without going in, or even just monitor while they're away from you. So something to look into. That's kind of my last little tip for anyone that does ortho.
N95 masks. They're there for your protection so you don't breathe in something bad. They're a respirator. So you're using it there for your protection. Use it all day and have other masks in between for the patients. Does that seem crazy? Does it seem bad?
For what they've been doing in China is putting, and in the States now, is putting a regular surgical mask covering the N95 to conserve the N95s. I mean, obviously,
the splatter and goo goes on that, then that goes. Yeah. If you do take off your N95 mask for whatever reason, as soon as you touch the N95 mask, you've kind of spoiled it.
Yes, that's my understanding. I think that's correct. So if you're treating multiple patients the same day and you're very low on supply, I think that's not an unreasonable thing to do. I guess other jurisdictions have done it. Don't know about the legalities, but when these are pretty tough times, if you don't have anything else, I think that's a pretty reasonable way of keeping everybody safe. Good suggestions.
Yes. Old folks home, not a stone's throw away from where I live. The staff go in, they have to sign on the dotted line, they get a mask. It's not an N95 mask. And then they have to use that same mask all day. And they have to sign that mask back when they go, so that the administrator of the old folks home know that they're not taking that mask home and then selling that dirty mask. They can dispose of that mask properly, but they get one mask per day. And they're in the lion's den because those are the poor people that have been dropping like flies on the North Shore in the old folks home because it got in there. And it's one thing in our dental world to have these great ideals, but as our supplies come down, we're going to have to be wise. And it's just a word of a caution. I think for some of these people who are using N95 masks like disposable razors, like, no, they're golden.
Yeah, if you have more supply than you need, there's definitely a lot of offices that do need them.
And disposable gowns. I believe your wife mentioned vets.
Where you might be able to source some.
Yeah.
They may not be doing as much work. They may have excess stock. We already talked about painter suits, maybe, as a coverall. If you don't have gowns, maybe some plastic of that nature might be better than others. Hard to say.
And then there's some altruistic dentists out there. I know it's not you, and it's certainly not me, who are donating their supplies to hospitals, and that's great and that's wonderful. But I think what a lot of people are forgetting are the community physicians, the outreach programs that are not part and parcel of the hospital. And these hospitals are getting everything, and the community physicians are perhaps not. And I've even heard in British Columbia that some of the outreach programs, the hospitals which have had goods donated to them are then saying, oh, we'll figure out how to bill you later. And you're like, those were donated goods.
So the family physicians, I'm not even talking outreach, but just regular your family physicians who are doing a lot of the swabbing, a lot of these initial screenings are exposed, and they are running out of supplies. And the hospital does have access to stockpiled gowns, masks. They have emergency stockpiles that they are probably not dipping into yet. Maybe they are, hard for me to say. But the family physicians do not have access to those same supplies. And so they only have access to what you and I have. And we know there's a big shortage. So if you can donate to your family physician's office, that can be organized through divisions on the North Shore. They're actually donating to other areas. So we can put a link on there. If you're in the Vancouver region, if you're outside the Vancouver region, talk to your local family docs. They are probably well short on those critical supplies. I think hospitals will have faster access to resupply.
Well, the government's even on the BCDA website, the government is controlling the import now of such goods, and rightly so they can get directed to the hospitals. And the problem is everyone's hospital, and wait a minute, family physicians and others are good too.
Everybody's going to the ER to get a swab, and that would create undue pressure there. So we need to keep those frontline people going so the hospitals can cope and not be inundated with mass numbers as well.
No, absolutely. That's a great points there, Kris. And Henry Schein, you brought my attention to Henry Schein. They have some recommendations. I read the list of business items to review, and they're rather interesting. We're shutting down our offices for extended periods of time. So what you may want to do if you do have in-house cable TV or something like that, cancel it.
You don't need it. Anything you don't need.
Yeah. I'm canceling my cleaners as of next week because no one's in my office. And at honest, we're pooling our resources. We're all working out of one office. So there's no point coming to my office to clean dust till we're ready to see patients, which is, I don't know when. And maybe phone Monterus and say, well, can I get a break on this machine or whatever? I don't know if we have to pay monthly things or whatever, but stick it to the man a little bit. Like, I know people are looking at rent breaks and that's good, but anyway, just a few thoughts.
They might do a two-month deferral only if you give them every piece of financial information you have. And I'm not sure if I'm ready to do that yet. When it comes back to lease time, they'll probably use that against you. So beware of offers with strings attached. I'd say, if you need to, you need to. But they do have some good recommendations as well beyond the business side, how to close down your office. Things you might totally forget. Well, running some line cleaner or line disinfectant to leave in the lines because you're not constantly flowing water through there. That might create a problem later. So it's a long list. Take a look through there. Definitely.
So, very interesting things. Anything that on a charger, take it off.
Yeah.
Fill
the battery.
Yeah. If you have bottles for your water, empty them out. You don't want, a pond scum developing and all that jazz. Anyway, the list is quite extensive. We'll have a link to it. It's quite useful.
All the things I wouldn't have thought of, but you might think of 3 of them, but there's 27 more. So definitely worth taking a look at. I know we're going to be going through that list in our office and make sure we shut down properly.
I'm sure the dentists in Ontario and Quebec would be able to relate to this very well. You're winterizing the cottage, right? So that's what we're doing with our office is we're winterizing it.
I think that's exactly
it. Getting it ready, mothballing it till actions are returned. Well, Kris, I apologize for all my numerous interruptions there, but I just got excited. You had so much great information. I couldn't help myself.
Well, thank you for all the good stuff you've given us. And it's a tough situation we're in. We just got to soldier on and do what we can. And I think from dentistry, it's not what we do, but what we don't do. The less we do in terms of spreading infection, the better. Treat those people that need treatment and otherwise stay home and enjoy the break.
Yes. If you had 5 top tips, and they could be lifestyle tips for our listeners, what would they be? What would Kris Klimek have to say? Guru Kris.
Spend time with your kids, family, loved ones. That's the top tip. You mean tips for when you're out of the office? Is that
whatever, man. The
I would say
yours.
Definitely do that. Pick up a hobby or learn to cook, something like that. And then take a look, talk to your bank manager. Honestly, I think they're going to be pretty hooked up with a variety of programs. Even just as we were starting to head into this, I was able to increase the credit line just in case, because we don't know how long. If you do it now, even if it's outside the government programs, having a little bit of extra room on a credit line might be feasible. It's still early days, so might not be a bad thing to do. Talk to your staff. One thing that we're doing, we're we've set up a little group, a little staff group on WhatsApp. They're sharing info. We're sharing info, pictures, all kinds of things. You know what? Everybody stays connected. That really actually helps. And, you know, you can kind of say, how you doing? And it's easier for them than just calling one person at a time. So like, that's helped us. And that's 3. And, you know, you're going to have to pay me for the next 2. So that's all I got.
All right. Well, it's one-stop shop for you, Sunshine. No. Yeah, the Henry Schein one mentions that too, talking to your staff.
Yeah.
Right.
It's a good point.
Yeah. Yeah. And
We're nervous. We're all nervous, but when we talk, we kind of reassure each other.
Well, and they could have some ideas too about how to improve the office. And it's time for you to stand back and
take some CE. Tip number 4: take some CE.
Yeah. Podcasts online are really good. Not this one, but there are some good ones out there. All right. That was fantastic, Kris. I think we covered it quite well. Any last words? I know I nailed you for the 5 there.
Yeah, I think, you know, anything else that comes to mind, we'll put an additional link at the bottom. Check back, and I think.
Yes, and when my 6 or maybe it's gone to 7 now, viewers watch this, they'll email you some questions. Todd and Doug are really good at asking questions. You know, okay. Michelle not so much, but yeah, you know, you'll get some questions, and then we can respond, and it'll be good. And
sometimes, you know, that's how we learn. I learned from talking to you, talking to other friends, and you know, we kind of, and actually that's the staff point. The staff have also taught me, okay, what do I need to look at to help them?
Yes.
Right. And so you don't have to feel like you got to do it all yourself by pooling knowledge from various sources. I think that's how we find it less pressure. So there's a lot of pressure to get all these things done right. Everybody wants to do the best they can for themselves, their staff. But by talking and sharing info, I think that's super helpful.
That's perfect. I absolutely agree. That's a great note to end on. Thank you so much, Kris.
Thanks for having me.
And we'll probably do this interview again some other time. I'm just going to have to save my pennies to pay you now. Now that I know the terms.
Now I know how I'm going to survive the next few months.
There you go. The Klimek files.
Not endo files.
That's right.
Till next time.
Yeah, let's see.